Well, Rosie, you did such a great job of introducing what it is that we're talking about today and who we are, that I feel I don't need to talk anymore about myself. So I'll show you, this is the campus, the University of Minnesota. Some of you are familiar with it and have received care here. The Mississippi River divides our campus in two, with pediatrics being on one side of the river and adults being on the other side. And I have crossed both sides and worked with both patient populations. And I'm just thrilled to be here with you all today. And I'll see if Kathleen, is there anything else you wanted to say about yourself or your lived experience?
Yeah, again, Rosie did a great introduction. I will share that I have a rare disorder myself. I was born with a condition called Moebius syndrome, which results in facial paralysis. And later on, I'll be talking about kind of my broad rare disease research and some of the kind of commonalities that we see across very different disease processes in rare diseases. And then I'll be talking about the study that Megan and I are currently running.
Great. Thanks, Kathleen.
And I think the next slide will show, yes, beautiful Oregon State University, where I am today. The view outside is much better than the view in here. And we have, beautiful mountain ranges on both sides, and we're about an hour from the coast. So it's a lovely place to be. And it's exciting to be able to collaborate with Megan, who is of course in Minnesota, and to collaborate with FARF, which is actually only about an hour south of me, in Eugene, Oregon.
All right. Well, Rosie did a great job of covering the objectives, so we'll move right past this slide. The first thing that Kathleen and I thought was really important to dive into was just to define what it is we're talking about today. One of the things that we've noticed in this work is that people sometimes have different definitions to describe what it is they're going through. And we feel really strongly that everyone in the FA community informs our work by helping define what it is that's important to each of you in your lived experience, whether you yourself have the diagnosis of FA or you're a caregiver that's living and caring for someone with FA. And so we want to give some of our definitions that we use from the literature, but also kind of hear from you all a bit on that today. So one of the, I would say, kind of buzzwords that's coming up in this area of integrative health and mental health has a term that's really emerged in the literature is whole person health. And I think that the Veterans Administration gets credit for really coming up with this term and using it most widely, but it's really taken on, and even the NIH is using it in their research now, and it's part of the language that FARF is starting to explore. So it's something that I'm interested in having a deeper understanding of. And I'm going to read to you, how the NIH defines whole person health. They define whole person health as health that involves looking at the whole person, not just separate organs or separate body systems. Whole person health considers multiple factors that either promote health or disease, and it means helping and empowering individuals, families, and communities and entire populations to improve their health in those multiple interconnected areas of biology, behavior, social, and environmental areas. And in whole person health, it's stated that instead of treating just a disease, we treat the whole person, and we focus on restoring health, promoting resilience, and preventing future disease across the lifespan. So I liked this image that sort of showed the interconnectedness between the individual. And so we know that within the individual, there are the biological, behavioral, social, and environmental components, but that individual is part of a larger kind of feedback loop, their family, their community, and the entire population that informs how well they feel on that continuum of health to disease. Recently, I had the opportunity to sit down with the Adult Council and talk to them about what whole person health means to them, or what they think of when they hear that term. And there was a lot of really powerful information that came out of that conversation. But my favorite was a quote from a young person who said during BMT was when they experienced feeling whole person health the most. And she said, I felt whole person health meant not only being healthy within the body, but also in the mind. Mental health is as important as anything else. A positive mindset can help you heal. The mind plus the body plus the support system equals whole person health. And I thought I really couldn't define it better myself. I'm not sure the NIH could define it better. And so what a fun kind of jumping off point for this community to think about. When I think of the evolution of whole person health and how it applies to this community, I think that scientists need to better understand the multiple connections, both within the person and, from person up to family and community. But also we need to understand the connections so that our clinical guidelines and our clinical care can catch up to this idea of caring for the whole being and not segmenting that care into different specialties or, disease categories or, phases of life. But as care teams, we also need more guidance and resources. I think patients and families and individuals living with FA may find themselves feeling frustrated at times when there's a lack of whole person care. And I just want to say really, openly and honestly with all of you that as clinicians, we also feel that frustration and that desire to better understand how to do this whole person care thing better. So I think we have a real opportunity to learn from one another and to kind of advance this concept together and even really co-create what this concept actually means on a deeper level. One of the other concepts that we often talk about, both in the care of people in the clinical setting, but also in the research realm, is well-being and, even quality of life. What is quality of life? What is well-being? And one definition that we use at the University of Minnesota is less about words and more about this image I have on the screen, which is the 6 dimensions of well-being and, how much they interact to define a person's well-being. What I've always liked about this model as it relates to my work with all of you is that health is one small piece of the puzzle as to how you're doing overall in terms of your well-being. And we all know that there are times we can be in really good physical health and not feel very well because we're not in good, in a good place, either from sense of meaning and purpose or a sense of security or relationships. And the converse can be true. You can be really struggling with your physical health, but be in a really good place in a lot of other aspects of well-being. So, when I think of well-being, I think of things like how content a person feels, how energized they are, how connected they are to the world around them. Do they feel balanced and safe and connected to their sense of purpose and meaning? But I want to, I think Kathleen and I both want to hear from all of you today, whether you're living with FA or caregiving for someone with FA. How do you define your own well-being? And if you would, throughout the next, few minutes, drop us a line in the chat of what's meaningful for you or what's an aspect that you want us to know as we kind of walk alongside your community to explore these concepts. So, as Rosie said, a big part of today's talk and, in the setting of talking about well-being and quality of life is to really talk about mental health and the spectrum that exists within mental health. I sometimes think that in an effort to destigmatize mental health, it got a little confusing. Where does mental health and well-being end and where does a mental health diagnosis begin, and kind of what is that spectrum and how do we define what it is that we're talking about? And I think it's really hard to piece apart this spectrum. We know that conventional, medications and therapies are pretty good at being applied to those diagnosable disturbances of mental health and well-being. So when someone has really obvious clinical depression or PTSD, we have some treatment algorithms to apply to that. But what we're not so good at is when someone's falling somewhere in the middle of that spectrum and they're not quite feeling themselves. They're not quite feeling like they're flourishing. They want more, they need support. But we don't necessarily have a treatment algorithm for some of those spaces in the middle of this spectrum. So we're hoping to talk a bit about that today. I want to just make mention that we know the incidence of all mental illness for all adults in the United States has gone up quite dramatically since 2020. We know that COVID introduced additional mental health challenges for a lot of people, both, from grief and anxiety and fear and trauma, but also from a state of isolation and people feeling disconnected. And we haven't quite returned to normal or leveled out. And, possibly some of that is because COVID just sort of uncovered issues that were already there or made it more acceptable to talk about them. There's one interesting organization that collects data on people who screen themselves for mental health conditions. So it's an online platform where anyone can Google it and find the 10 most common mental health screening tools that are used by clinicians, and they can screen themselves, and then their data kind of goes into this database. And in 2021, that organization saw almost 500% increase in people who were screening themselves for mental health diagnoses, and 103% more from 2020 to 2021. So we know it's continuing to rise. So we know that COVID had a profound negative effect on mental health. But I think in some ways it's good that we're talking about this. We're talking about depression and isolation and grief and anxiety, and identifying the problem is kind of the first step in making positive change as a society. So let's see, I'm getting a little rogue with my slides here. I hope you're able to read these okay. I know they're not perfectly designed slides here, but what I wanted to do was take these kind of green bubbles of the continuum of mental health and well-being and break it down into what might that feel like in your mind and your body. If you're sitting in the audience today and wondering, I don't know where I fall on that spectrum, I've not had anyone talk to me about my mental health yet. These just give you some kind of ideas as to where you might place yourself on that spectrum. And I think it's important to know that we all fluctuate back and forth. So these are just illustrative, but not at all meant to be a complete account of all the things you might experience. So the things in these bubbles represent things like healthy relationships and connection when our mental health is intact. We have that sense of meaning and purpose, and we're getting enjoyment out of our daily life. You feel like even though life throws curveballs and we have ups and downs, when your mental health and well-being are really intact, you feel like you can respond to those and you can rebound quickly from the lows. And you have the ability to really think clearly and put things in perspective and accomplish the tasks and responsibilities that you have. When you start to feel some mild disturbances in mental health, you might notice that you're lingering a little more in the negative. Maybe you're ruminating, maybe you have difficulty falling asleep, but it's pretty isolated to the time around a stressful event, whether it's, just losing sleep the night or two before a medical appointment or a scan. Maybe a little more stress you notice when you're going in for an appointment that used to not bother you so much, but now you're feeling a little more sense of dread or rumination about that. Maybe you have an occasional question around your sense of purpose and meaning, and some days where you're feeling a bit lower, but overall you're still, finding areas of joy. But maybe those feelings of disconnection are starting to creep in. And then when we get into the realm of more moderate disturbances in mental health, you start to notice difficulty falling asleep more often, not always connected to a specific event, noticing that the lows last longer, and it's harder to bounce back from them. And you're just sort of sitting in a place where you're kind of waiting for maybe the next bad thing to happen, or not feeling like you're getting the highs to balance out the lows. When we get to that point, we start to struggle with our sense of meaning and purpose, and we notice less joy in our daily lives. We also notice we're starting to feel a little more disconnected, maybe spacey, maybe like your body and your brain or your mind are not in the same place, in the same room, and that's impacting your relationships. And then when you get to the point where you probably have a mental health diagnosis, that might look like nightly difficulty sleeping or having nightmares, waking up early because your stress hormones are really pulsing through your body in a way that's not allowing you to go through and complete that full circadian rhythm and get through all the cycles of sleep. Maybe you're feeling anxious or depressed more days than not. You've really lost a lot of daily joy and lost connection to your sense of meaning and purpose. And you're feeling really disengaged from your relationships, or other people are noticing and saying to you, you seem to really just be going through the motions. So that kind of gives you maybe a little deeper dive into the areas of that spectrum that you might think about if you're wondering where to place yourself or how to start having conversations with your care team. One area of mental health that I want to pull out and spend just a few extra minutes on is trauma, because I think that is an area of mental health that is, both poorly understood and starting to become really talked about. I would say that trauma has even become kind of a buzzword, and people are kind of grappling with what is trauma. So there is a whole spectrum of how trauma is experienced, and it's very personal. And we don't have diagnoses to describe everything on the spectrum of trauma. We have the diagnosis of post-traumatic stress disorder, but we know that not everyone who's struggling with trauma fits into that diagnostic category. And when you don't fit into a diagnostic category, sometimes it's nice to not, have a pathological diagnosis for everything you experience in the human experience. That's a normal reaction to hard things in life. But sometimes it's hard to get the help that you need at the same time when you don't have a diagnosis. So those labels are sort of a double-edged sword. And I think that medical trauma and caregiving trauma is an especially tricky kind of trauma to understand, to identify, to work with, because so much of what you go through on a daily basis is really hard. And the reactions you have to it are actually really normal human reactions. And the kind of compensatory mechanisms that you come up with to help you cope are really normal, healthy coping strategies until the balance kind of tips. And then you get to a place where you're experiencing more symptoms and you're struggling more. And it can be hard when you're living in what some people call small t trauma, or, daily small, hard things. It can be hard to identify a tipping point versus, big T trauma, which might be, a tsunami came and wiped away my house. That's pretty easy to identify as a traumatic experience. But micro traumas that occur day in and day out sneak up on us, and they're harder to understand, and they're in a lot of ways almost harder to treat and to work with in the human condition. So, what does all this mean for the FA community, and how might you put this into, in relation to what you're experiencing? So, as you all know, in FA, there's not always answers in the literature, and we have to sort of draw from what we know about other areas of the literature. And so I I have a little bit of information on the next couple of slides about cancer survivors, and then Kathleen, I'm going to hand it over to her, and she's going to talk about rare diseases or rare disorders, because when you have FA or you care for someone with FA, you're sort of living at that intersection. We don't have a lot of specific information in the literature yet telling us what the experience of living with FA is like. But we can imagine that what someone living with cancer experiences and what someone living with a rare disorder experiences, you might be somewhere in the middle, with some similarities and synergy between those two populations of people. So this is kind of the summary of about 60 different studies that were looked at. And of those studies, most cancer survivors experienced depression, anxiety, neurocognitive dysfunction. So that could be a wide range of, just difficulties thinking in the same way that you used to think before treatment happened. We know that cancer survivors also experience sexual dysfunction or disturbances to their sexual well-being, sleep disturbances, a lot of stress-related disorders, or those trauma-related disorders, PTSD, post-traumatic stress disorder, thoughts of wanting to harm themselves or not wanting to be here anymore, suicidal thoughts, and then what we call somatization, which is when mental symptoms become so much to bear that they kind of morph into physical symptoms. It's sort of the mind's way of not processing the mental pain, and it sort of morphs into physical pain and becomes very confusing to try to understand the origins of it and how to treat it. We also can look at the literature around caregiver mental health. Again, this comes from caregivers of people diagnosed with cancer. And we know that they also suffer more than the general population. We know that spouses of cancer survivors are more likely to have mental health disturbances, but we also, in a hopeful light, know that because the care of the person with the diagnosis and the caregiver are so interlinked, we know that if the person with a diagnosis seeks mental health care, then the caregiver is more likely to seek mental health care, and the converse is true. And so even though caregivers experience a lot of challenges in terms of being able to have the time and the money and the access to taking care of their own mental health care, we know that their mental health outcomes are really linked to the person that they care for. So I think this just really tells us that family-centered care that puts the family unit and the community at the center and thinks about the interconnectedness is an important lens for us to look at this, and that we can't care for the patient without caring for the caregiver. And when we do a better job of caring for the patient, we allow the caregiver to have space and capacity to care for themselves. And as a community, we have to be a part of that care of the entire family unit and not turn it into an additional job for the caregiver, but really a wraparound service for the entire family unit, knowing how interconnected the health of the person with the diagnosis and the caregiver are. So, in short, we should be offering more psychosocial or mental health support to both people with these types of diagnoses and their primary caregiver. And of course, this particular literature focused on spousal caregivers, but I think it's really safe to extrapolate and say that that could apply to anyone's primary caregiver. So Kathleen is going to talk to us now about the literature around people with rare disorders, and then go into talking a bit about the study that we're working on. So off to you, Kathleen.
Thank you so much, Megan. Great job kind of queuing up these ideas. And what I'm about to present around rare disorders really parallels what Megan was just saying about the literature on cancer survivors. So as she alluded to, people with FA kind of live at this intersection between those two groups. Fanconi anemia is considered a rare disorder. In America, we define rare disorders as any condition that affects fewer than 200,000 Americans each year. And actually, there are quite a lot of rare disorders, more than 7,000. And in fact, the collective experience of having a rare disorder is common. 1 in 10 Americans has a rare disease or disorder. So I always like to highlight that when I talk about how kind of how it can seem so isolating to have such a unique disorder. But I, as a person with a different rare disorder, have really found insight and solidarity connecting with other people and doing research on conditions that might seem very different to mine, but seeing some commonalities in our psychological experiences. So, only about 5% of rare diseases actually have FDA-approved treatment. So that really makes it super important that we support the overall well-being and quality of life for people, especially focusing on those psychosocial things that we know we have some great interventions for. So some of my research in the past has pointed to these universals across very different disease processes. So one is the need for specialized support. People with rare diseases have an average diagnostic delay of 7 to 9 years. So that is a very long time to go with uncertainty, with confusing symptoms. Many people report feeling like they're being medically gaslit. And then about 2/3 of people with rare disorders feel that they do not get sufficient support through the healthcare system. Part of that happens during that diagnostic odyssey, but even when people have their diagnoses, it's so challenging to find providers who have expertise in a condition. Another universal that we think we're finding is isolation. So people with rare disorders and their families want to meet others with their condition, but most have never done so. And this happens to be this is caused by the rarity and geographical isolation that happens when we have rare disorders. So if you could go to the next slide, Megan, I'd like to talk about some things that can help with these issues. So one thing that we find to be very promising is social support. And Megan was already alluding to the power of social connections. In psychology, we can divide social support into 4 different types. And we should aim to give and receive all types of social support throughout our lives. It'll wax and wane in the seasons of our lives, but we should be experiencing companionship or feeling like we have a group of people that we belong with, that we can just hang out with and spend time with. We should have emotional support, meaning we have people who make us feel understood and validated. We should have informational support. So this is especially crucial with a rare disease. You need to have a trusted source of information that can provide you useful knowledge. And we need tangible support at times. So this could be very concrete things like helping with tasks, having someone who can bring you your groceries if you need them, who can help with your meals if you need that. And I've been kind of perusing the very insightful comments that y'all have been leaving in the chat, and I thought it was really neat that people have mentioned the value of giving support as well, helping others, and we really do find that that can be one of the most powerful aspects of social support. And so I want to give one example of a study that we previously did. This study was focused on the rare disease that I have, Moebius syndrome, but we are now expanding it to look at other rare disorders as well, because we think that this may be beneficial in a variety of conditions. So many support organizations, including the Moebius Syndrome Foundation and FARF, of course, hold support conferences for people with the condition and their families and researchers to come together and get to know each other and get support. And so we studied the Moebius Syndrome Support Conference. We examined people who did attend those conferences and those who didn't, and we found that more regular attendance at those conferences was associated with reduced stigma, with increased social support, increased knowledge, and increased self-efficacy, or the confidence to care for and manage one's disorder. And the neat thing about this, that much like what Megan was sharing, this benefits both the people living with the condition and, in this case, their parents who attended. So getting this social support can be really helpful for the whole family. Next slide, please. Thank you. And so now I'm going to transition into kind of a few ideas around how we can intervene on mental health and well-being. And I'll focus on lifestyle interventions, integrative therapies, psychotherapies, and medications. And while this is not the focus of our talk, because we're really going to be talking about how we can learn about your psychological and mental health experiences, we did want to be sure that we provided some kind of pointers about where you can get more help if you need it. So there are a variety of lifestyle interventions that you can try on your own or in consultation with your healthcare team. So this can include being sure you're getting adequate, healthy nutrition, being sure that you're moving in a healthy way, that you're getting enough sleep, that you have strategies to manage your stress, that you're able to spend time in nature, which can be quite restorative. Often, moving in nature can be a fabulous combination if it's accessible to you. Avoiding risky substances, especially with Fanconi Anemia. Having those positive social connections that we've been talking about, and ensuring that you have free time to explore your own creativity, hobbies, and just have leisure. Maybe you'll spend some of that time engaging in companionship support with others who you feel you belong with. And then there are integrative therapies that you may be interested in exploring as well. So there's been found to be some really helpful benefits to mindfulness and to yoga. Acupuncture in some situations can be helpful with stress and pain, similar with massage and supplements. And then there are also kind of taking a step up from working on hobbies, you can kind of incorporate creativity into therapy through art and music. And then if you find that you've tried some of these avenues and you're still needing more help, you don't have the mental well-being that you are hoping for, that is the time to talk to your healthcare providers about perhaps getting a referral for psychotherapy, and also perhaps talking about medications. So psychotherapy has a number of evidence-based ways to navigate the common challenges that we see in cancer survivors and in people with rare diseases. So kind of the gold standard classic is cognitive behavioral therapy. And that is a type of therapy that focuses on the thoughts that you have and considering whether those thoughts are accurate and healthy, and also kind of thinking about the precursors and things that happen after your behaviors, and working on ways that you might modify those thoughts and behaviors to have a more healthy life that you desire. Acceptance and commitment therapy is like the next stage of cognitive behavior therapy. It's kind of a new wave of CBT, and it builds on it. It has a lot of good emerging research supporting it. It builds on it by encouraging people to be not only aware of their thoughts and feelings and behaviors, but also to validate them and to accept them. Often this involves some mindfulness exercises. So this type of therapy recognizes that, hey, we're going to have mental and physical pain, and it's not always a reasonable goal to completely eliminate it. It's a goal to live with it. And as I said, mindfulness and various meditation strategies can be really helpful in learning to accept some of these things that we cannot completely change. And there are two new forms of therapy that are especially good for trauma, trauma-focused therapy and eye movement desensitization and reprocessing, or EMDR. Now, these are both therapies that can be provided by a psychotherapist or sometimes a social worker. And then there are certain medications that can also be very helpful with symptoms that you're struggling with. And sometimes your general healthcare team can prescribe these, and other times they may decide it's more appropriate to refer you to a psychiatrist. And these medications would include antidepressants like SSRIs, This would include anti-anxiety medications, and then medications to target underlying symptoms like pain that you're experiencing or sleep disturbances. And so again, you want to have an open communication with your healthcare team if you are feeling you need more support, because there are a lot of different types of providers that you could be referred to. So this could range from working with a dietitian, working with individual or family therapy, working with sleep medicine, which is a whole branch of medicine focused on improving sleep quality. It can be very beneficial knowing our links with sleep and mental health. There are teams focused on chronic pain and palliative care, and also, of course, talk with your healthcare team if you're interested in gender care and gender affirming care. So I want to transition now to talking about the study that Megan and I and our team are actively working on. And we're really excited because, as we've been alluding to, there's not a lot of research right now about the experience of actual adults with Fanconi anemia. We're pulling in data from the cancer literature, we're pulling in data from general experiences of people with rare diseases, but we want to co-design with people with Fanconi anemia a study that will really put this experience on the map and give us a framework to move forward with. So with our study, our general goals are to better understand the mental health risks of individuals who are living with Fanconi anemia. So specifically, we will examine how many people in the FA community live with anxiety, depression, and post-traumatic stress disorder. We'll examine what increases the risk for some of those disorders and also what can protect against those risks. We're also interested in examining how people are engaging with FARF services and how those are helpful, and how they could be more helpful. And we're looking at how people's intersectionality, their lived experiences, their backgrounds, their races and ethnicities can impact their mental health and their access to mental health care. So I think the part of this study that is most exciting to our team is the fact that it is participatory action research. And what this means is, this is a research paradigm that is really focused on involving the people who have a stake in the challenge in conducting the research. So here we are conducting research with, for, and by people with Fanconi anemia. And what that has looked like for us has been holding a listening session with FA adults before even submitting a grant to FARF about what we want to study. We wanted to talk with the community and, of course, use our experience working with these populations before. And in particular, I've leaned heavily on Megan's long, nearly 10-year experience working with the FA community. And then as we were developing the grant, we had a lot of expert feedback and guidance from the FARF team. And then once we received funding for this grant, a crucial part of that funding was to pay an advisory board of adults with FA for their expertise and time. And so we have assembled our advisory board, and they really work with us at every stage of the process. So they have helped us define the most important things to study. They've ensured that we have the best tools to capture the things that matter to people with FA. And, because we are very tempted to measure everything under the sun because we really haven't gotten the opportunity to study mental health in people with FA before. We also rely on our advisory board to kind of rein us in a bit and be sure that we are biting off a reasonable amount, and especially that we're not overburdening people with FA with long surveys. So we wanted to be sure that this is something that people who have, stressors and on top of their daily lives and mental and physical health issues that they can engage in. And then our board is helping us to share the survey, and we'll be doing some of that today as well. Be sure that we can get as many people with FA with different perspectives and backgrounds to give us our perspective. And then finally, they're going to be helping us make sense of the things that we find in the survey. There's no one who will understand the meaning of our results better and how they can be applied than community members. And I want to recognize our advisory board here. So we currently have 4 members, and they are Jasmine Bennetson, Sean Brenniger, Anna Cho, and Dexter Sherrill. And we also want to dedicate all of our work to Angela Bedoya, who many people in this community loved and remembered, and who was crucial in shaping the first phases of our study. So what does this project look like? Well, it has 2 parts, and the first part is this survey that I was alluding to. Our goal is to collect experiences from 100 adults living with Fanconi anemia. And this survey takes about 40 minutes or so, and includes questions that were shaped by our advisory board around quality of life, the incidence of mental health disorders, and demographic and intersectional information. And as I mentioned, these were all designed with our advisory board. And then the second part will involve selecting 15 people from our surveys to then contact and ask deeper questions about FA. So we will have in-depth interviews that probably last about 45 minutes to an hour with each of 15 people to really dive deep into what they're experiencing. And an optional component of this will be something called photo voice. And photo voice is a neat strategy that it often goes hand in hand with participatory action research, where we encourage our participants to use a camera or use their phones to capture photos that illustrate their experiences. So we will give participants prompts like, show us what FA means to you, or show us the type of support you need most. And some prompts like that may inspire people to take photos that they can then bring back to us, and we can have a conversation with them. They're kind of like a conversation starter. So we can talk about, what prompted you to take this photo? What inspired it? Tell me about, what is meaningful here for you. And the neat thing about this is with our community members' permission, we can also use these photos as ways to communicate about the experience of FA to the broader world, right? We can share them, again, with their permission, in presentations like this. So hopefully in a year or two, we'll have some really compelling photos that illustrate what people are going through. So we expect to find that, much like the cancer community and the broader rare disease community, that mental health disorders will be more prevalent in adults with FA compared to the general population. But I think the thing that we're most excited about is really finding the protective and risk factors that are associated with mental disorders, so that we can help people leverage those. So we think some protective factors will include having a positive identity around FA, having social support, engaging with FARC, rare disease self-efficacy, spirituality, avoiding and resisting stigma. We think that many people may also struggle with concern with death and dying and body image. And these are things that we would like to try to find interventions for. And we also, of course, think that specific symptoms and characteristics of FA may make some people's challenges greater or less. Similarly, some people may have intersectional experiences with race and gender and sexuality that can make things more challenging or less challenging. And so we're interested in looking at all those factors. So on part one, the survey, we currently have 45 survey participants. So that's really exciting. We're about halfway there. And we need your help for the other half. So we have these flyers that we have been sharing, and with FAR's help have been sharing with the community. So I'd just like to tell you a bit about what it would look like if you participated in our study. So number one question is, how do I participate? And the answer is to email us. And I'll have our emails are here, and I'll have some info in the following slides about how you can do that as well. So you could participate in our 30 to 40 minute research survey. It's available online. It's also available in a printed mailed version upon request. And if it is preferable to you, we can also do this as an interview if you're finding that it is challenging or energy depleting to do a physical survey. And it's available in English and Spanish. And all participants are compensated with a $40 gift card. And of course, you must be diagnosed with Fanconi anemia, and the only other requirements are that you be 18 years or older and be able to communicate in English or Spanish. We welcome participants from all countries. So at this point, we'd love to open it up for questions and feedback from the audience. And we also have a couple of slides with references and contact information.